Let's open this with a story that aired on NTV, that there's a crisis looming in public health facilities. Women are increasingly being turned away from family planning clinics due to a shortage of contraceptives. What was once freely offered in large supply under donor funding has since dwindled, leaving families struggling to align their family life with their economic capabilities. This was a story that was done by Ngina Korir, conducting spot checks across several facilities and holding candid conversations with affected women. Many reveal they've been forced to resort to dangerous alternatives. So let's take a look at that story and then come back and begin our conversation in studio.
It's a typical Monday morning at this public health facility in Nairobi. Patients, mostly women, occupy the waiting bay. Some of them mention that they are here to receive a contraceptive as part of their family planning methods. However, there is a problem.
The
receptionist directs me to the pharmacy, but yet another rude surprise awaits.
Family is not working at the moment.
It's not working?
Yes.
Huh?
Yes, right. They started like that. So the family call aina mtu sahihi family planning, the maternity, the total pharmacy.
This is not just a random tip-off. It is a complaint that has been pulled from numerous women who say that their family planning methods, which were previously offered for free, have become a scarce yet a critical resource, following the cuts to donor funding and no alternative from the government. Raging strikes by healthcare workers also mean shut doors and empty halls as patients continue to suffer. To confirm this, we spoke to several women. Our first stop was Mathare, where we met Sadia Bule, a community volunteer in the area.
Hiyo ilikuwa inatusaidia kucheza safe game hata wamama kama sisi beyond hata wasichana kwa sababu kuna changamoto yenye wanapitia yenye hawajui.
A family feud forced Amina Nyongesa to flee from home. She then moved in with her partner. However, to ensure she properly plans her family, she visited the local government clinic to consult the doctor there.
Kaniambia kama nataka kupatia dawa nimpatie punch ndio nidunge hiyo dawa. Ili ni affect juu sina kazi, sina do. Kenanga hivyo ndo nikakujanga nikapata mimba.
The scarcity of the medication has led to some clinical staff asking for bribes so as to administer contraceptives to girls and women.
Juu hakuna dawa na mtu already ashakona mimba na mtoto mdogo. Juu dawa hata pia kwa chemist ukienda unasikia mara dawa ziko. Saa zingine unaweza pata daktari mwingine kwa chemist anakuambia we suni chota kitu kidogo nikupe dawa chini ya maji.
Wazungu wakiisha sisi pia tuishi. Tufai kila mtu tunafaa kuwa na mkataba yetu na mtaratara vile tunaweza ona tusaidie wenzetu pia kwa sababu ni wetu na ni madada zetu na tufai kuacha nyuma.
Equally dangerous to the lack of legit contraceptives is the availability of cheap alternatives which women and girls are resorting to.
Kuna wengine wanatumianga hizi dawa zenye zinaitwa pitu. After washafanya wanaenda na buy pitu. Ndio hiyo at least pia wasaidie juu hiyo dawa ukienda unauziwa.
The shortage of contraceptives is also being felt in Dandora area.
Naona hii I was not ready to conceive anything, but juu nilinyimwa, nilikuja sasa ile kujiprevent yenyewe ilikuwa ngumu juu siwezi tumia anything, nikajipata niko kwa hiyo situation. Sasa unapata kama mtu kama mimi I was not ready for it, lakini inabidi tu uibebe juu ishaingia.
Serikali ingilie kati kama ni mazungumzo waweze kuongea zirudi, Wakenya wanateseka like obviously hapa kwa Islam ukitembea nje watoto wadogo they are pregnant.
A response from the Director of Family Health at the Ministry of Health, Dr. Bashir Isaac, offers vague timelines on the ministry curbing the family planning crisis. He states that we are mobilizing resources from within, from partners, and the procurement process is ongoing. The shortage of contraceptives completely obscures the word planning in family planning, as many communities had the rug pulled from under them with the cuts to donor funding, with the government giving no alternative to seal the gap in family planning methods that many communities depended on. Ngina Kirori, NTV.
That is a very worrying picture, and it's pretty much just the beginning of what is likely to turn into a massive crisis. But let's welcome our guest this morning. Like we mentioned, David Khaoya, health economist, the impact of funding cuts on Kenya's health sector. Thank you for joining us.
Thank you.
Okay.
Do
we just go in?
Yeah, let's just go in.
Go in, Mariam. Go ahead.
No, because it's like it decode
yes. Yep.
But looking at that story, it's incredibly worrying. I see several health, issues, public health issues coming to fore. But let me begin with exactly how much of our healthcare was being funded through aid, and what stopgaps have been put in place to, kind of stop what's happening, what we were seeing on the screen with Ngina.
Okay, so thank you very much. I think to better answer your question, I think let's look at some of the analysis we've done in the past to give a context in terms of like what is it that we are talking about. So the government prepares what we call the national health accounts. This is an estimate of exactly who funds what. It gives the structure of funding for health services in this country. And we realize that if you look at the proportions, the government funds to the tune of 53%, donors or external funding to the tune of 18%, and then we have households and private sector generally at about 28 or 29%. So basically what we are saying is that we are talking about that component of 18%, which is now being affected. Of course, there are other dynamics in terms of like the reforms that have come in and how they have affected that structure. But that report was actually done like 6 years ago, but the structure of funding normally does not change that much over time. So when we now contextualize that, and then we come to exactly what happened early last year, when the new US government came into power, they issued a stop work order, which basically suspended foreign aid to many countries for a certain period, pending their alignment of the foreign policy to ensure that their funding adheres to certain norms that they had agreed upon as a country. And so the biggest player here was the US government. But in our analysis, we said, let's not just focus on the US government because there are other donors and they can also easily withdraw. Right. And that's why we looked at it in a very comprehensive way, trying to look at what was it that the total that they were bringing in, which channels they were using to basically fund us, which areas were they supporting, and we were doing that so that as we follow the money, then we understand where the impact will be. Because it's like when you get a child who has leaked your sugar, you look at the mouth, then you realize, oh, this one has leaked my sugar. So we were trying to look at that type of analysis, and we realized that there are certain diseases that have really been relying on donor funding, and one of them is what we've just seen on your clip here, where reproductive and maternal health services. We have malaria, we have HIV, TB, and so on. So although the overall is 18%, but when you focus to those diseases, then you realize that the percentage actually increases, and so on. And in fact, when you go to the specifics in terms of commodities and other items, you realize some of them actually rely to the tune of 85% on donor support.
And thank you for painting that picture, because we know when you said 53% government funded and then 18% donor funding and the rest is household, I was like, hey, Daktari, is this on paper? Is this the situation on the ground? But I think you bring in that context of specific programs and specific areas that have heavily relied on this. Now, early 2000s, or is it 99, Kenya declares HIV national crisis. And then we needed to come into programs to basically support this. For that past 25 years or so, how much did government actually put into this sector as compared to external funding? The national crisis, the national health emergency, how much did the government of Kenya actually fund?
So and it's good you have brought that issue, because sometimes we ask, how did these things start? How did we get ourselves here? As you know, it was actually a crisis, and there was need to come up with interventions that will definitely deal with the crisis at that time. I remember HIV used to be the way COVID was the other day. You could not even move near a burial site. People used to be buried almost half a kilometer when the mourners are waiting over there. But then, of course, those interventions have now brought us to where we are. And so in terms of support, we know, I may not have the exact figures, but we know the extent of donor support has been quite huge. In HIV alone, the commodities, about 63% of commodities, we've been relying on donors' support. And so you are talking about somebody saying, now I can't support. It's basically stopping with your 63% of what you need. And that's why you see what you've just aired. And when we go to areas of human resources, for example, they also support workers. So you go to a facility and then you realize there are people there who are working, who are supported by the donors and so on. So the impact is exactly in those areas where the support used to support before.
Yeah. And these were critical areas as well.
Yeah, exactly.
Because you're talking about vulnerability. When you say HIV and then you say TB and malaria and other opportunistic ailments there, it's where you cannot wait.
Yeah,
exactly.
If you pause, it has a direct and immediate effect on your health as well.
Exactly, yeah.
Now, from your research, did government at any point have any conversation about reversing this funding and reliance on donors? Before last year?
Yeah, so there has been a lot of conversation in terms of what we call transitioning from donor support to domestic support. And this conversation, if you go to the literature, you will read transition reports dating back to the 1990s. But in terms of actualization, I think that's where the problem has been. And partly is because the donors have been there. Why would I ask them to leave if they are still funding me? So in a nutshell, there has been that conversation. It's only now that now it's urgent. We need to start looking at exactly what do we need to do now so that we can now fill the gap that the donors are creating as a result of pulling out. So you will find in the ministry there's a lot of literature around transitioning, especially on vertical programs. Vertical programs are those programs that have largely dependent on donor support. And so documents are there, meaning that the government has actually been aware and in a way prepared.
Prepared.
It's just that
in a way.
I want to come to, at some point, domestic funding, because I feel like we need to figure out what that looks like.
Exactly.
But just based on what we just saw, realistically, how long can hospitals manage before they need the replacement of funding or contraceptives, etc.? From your perspective, from your research, what are we looking at? Already we are seeing this gap. How much longer can this be pulled until now we need something urgent to come in?
Yeah. So different programs have been planning in different ways. You will find them having stock cover for 6 months, 8 months, 9 months, and so on. So what we are seeing is actually the expiry of that period, that some of that period has lapsed. But there is another point which we need to emphasize here. There could be a shortage in one facility, but an excess in another facility. So there are also those system challenges that need to be worked on to ensure that we balance out and transfer stocks from excess to supply, deficit areas. And some of that work is actually driven by information systems. If you are seated here, you will not know that Bungoma or Kilifi has some excess. Meanwhile, some place here there's a shortage, and that's why the support to systems, information systems, also become critical. Because sometimes people, when we ask now, which one do you think we can do away with? People say, no, I think let's do away with the systems for now. But look at it, that system can also help you solve a problem, like what we have seen here. You will be surprised if you called around some of those commodities that people are complaining they are lacking, they are in excess in some other area. Simply because the system that we are supposed to rely on was also supported by a donor.
Yeah.
And therefore...
Donor went to its sister.
Quite literally.
Yeah,
Oh,
yeah,
God.
literally.
No,
Of course, they didn't carry it away.
They left with it.
Yes, yeah. So strengthening such systems also is part and parcel of the health sector strengthening. Yeah.
From an economic perspective, I'm thinking through what this looks like 5-10 years from now. Even if, let's say, by the end of the year, we've managed to stabilize and to plug all the holes left by donors, still, that's a year of without access to contraceptives for a lot of young women, like you've seen. There was delays in antiretrovirals for a while. I know, they worked on that. What does that look like from a trickle-down effect when we look 5-10 years down the line?
Yeah, and that is the work our organization, Center for Epidemiological Modeling and Analysis, is working on, to try and look at what does it mean not to take ARVs now for a patient who is HIV positive.
Right.
And those are findings which I think at some point we will come to discuss, because our focus in this report was to look at that immediate impact in terms of what is it that has been plugged out, and therefore where do we need to start plugging in and so on. So in terms of the health outcomes that will arise as a result of patients not taking ARVs, as a result of patients or women not having contraceptives, now we will be seeing that coming. Because, like I said, if you quickly rush to look at some health outcomes, you may think they have improved because there was no system to even capture the deaths, for example. So if you quickly go to say, okay, as a result of the withdrawal, we see that mortality has reduced, you will actually be giving a wrong story. It's just because there was nobody to report, nobody to capture that information.
It requires nuance.
Yeah.
Okay.
Yes.
Let me talk about TB and malaria. They're perhaps not so talked about as far as these funding cuts are concerned. Ngina has done a nice story on maternal health, on contraceptives. We've heard a lot around access to ARVs and to healthcare for persons living with HIV. TB and malaria, not that talked about.
Yeah, we must commend the government, because I think after the withdrawal of the funding, there was a lot of realignments, both at the county level and at the national level, to try and see how to fix some. As you know, the vertical programs had verticalized services, and so there was a lot of push for integration, trying to combine services that will be provided at the same time. And also the beauty is that some of the commodities we already had them. So that's why you see the impact coming now, because if you had commodities that will cover you for 8 months and then or 1 year, then you may not see the impact immediately because you are still swallowing those commodities now. But of course, as time goes by now, there are arrangements to see how does the government plug in, how do other donors come in to support and so on. So that could be the reason why you may not see that type of impact now. But of course, if you look at the stock levels and so on, you will definitely see that there are certain things that have actually moved as a result of not having funding coming from where it usually came from.
I wanted to get into domestic financing.
Yes.
We have economic constraints, so realistically, what does raising money domestically look like? Also, how are we balancing debt and protecting health? It's a very tight place to be, but domestic financing is something that should have been prioritized a while back. What does it look like realistically now?
I think let me also make a point here, because those are not two things you balance, because one is mandatory. Debt is mandatory. Before you start balancing, you must have paid debt.
Yeah.
It's called.
I thought the other one. I guess you're going to say health is mandatory.
As a charge.
That's the first charge. Any money the country collects, first they pay debt. So we are basically coming on the table to share what is left, and that is
our constitution guarantees us that health is mandatory as well. So both are mandatory.
Because
debt is a first charge. Health is mandatory.
If we were allowed to do that, then we will not be repaying the debt that we've borrowed out there. And so it's what we call mandatory or first charge. So whenever the government is sharing funds to departments and ministries, they have already netted off what needs to be paid to external funders.
Yeah.
Yes. So that's why I'm saying there is no balancing there. It's just taking what is left and then trying to see how do you balance what you have left.
Is left. But yes, I added a word there. Character development ni ngumu.
The little that's left.
The little that's left. But yes, and then now you wanted to comment on that thing for debt.
Yeah, had you finished that?
Yeah.
The line of thought. Okay, so Nisawa, we have collected money. Nisawa, we have paid for debt. Nisawa.
Yes.
There'll be questions about why we borrowed and what we used the money for.
That's for another day.
That's for another day. The money that's left, are we prudently utilizing it?
Yeah.
Because I see one of the recommendations that you're saying is in the short term, for example, in the next financial year, the government should prioritize and increase health allocations to cover strategic commodities and maintain critical information systems, working with the COG to support counties in absorbing essential human resource for health that were previously funded by donors. We've been having them. Global Fund guys are still out there 18 months without pay. 18 months. Same with the others that were for the COVID time. Now, we have money that can do this, Daktari. We need to stop telling these guys to stop giving us these stories that they give us. There is money that should be able to be allocated to this if we prioritized health as what health is, right?
Yeah.
If you look, I mean, you're an economist. Ukiangalia hiyo pesa yote tunatumia. Is it possible for them to actually say, this is a priority area, we can fund it?
Yeah, so we need to understand the prioritization process of many things that we do as a government. So the budgeting process is a political process. So as we prioritize health, we are also supposed to also prioritize roads because we promised to build a road somewhere. We are supposed to prioritize a market because we promised and things like that. And that's why I'm saying it's a political process.
Yeah.
And so we are talking of a situation where we have limited resources against unlimited ones. So the issue is that which one do we prioritize? So part of what the process is, and the challenge for health has been, how do you go to lobby for additional funding? You know, education sector is easy to lobby. You go with the number of pupils. You say, I have this number of pupils.
And every day they will go to school.
For every child, I need so much. Which story do you go with when we are talking about health?
We have the numbers.
You say people are having severe malaria. They say, where are they?
How many?
No, but we have the
that data should be there.
Do we not have the data?
Yeah, but you see, there are so many diseases. So as you finalize with malaria, somebody comes and says, you see, there's also this trypanosomiasis, which is attacking people.
No, aggregate.
Chikungunya.
Aggregate with line items. We have this many. Last year we treated this many people with malaria. It cost us this much.
And then
and this year it's going to be hotter and rainier.
And we're
we're anticipating times 1.5. Then ongeza trypanosomiasis.
And then put chikungunya and dengue fever.
And when you do that, it exhausts the entire budget.
Well, that's just bad manners on our part.
Let Treasury deal with that.
Yes.
You come with your budget.
Exactly. So what Treasury does is to give what we call a ceiling. They say, this year we are able to give you so much. So you go back on your drawing table and then say, okay, out of all the diseases we have, this is the budget we have been given. So where do we put our money? Do you buy anti-malarials because it's affecting many people, or do you buy anti-tropical and infectious disease commodities because they affect few people but they are very fatal and things like that? So there's a lot of balancing, like you said.
You know, I hear you, and you make very valid points. But I'll also now counter with this. For the last 15 years, let's even go into the end of this administration. The government's focus has included health.
Exactly.
Big four, top five, whatever, it's health is right there as a key. So it's a political tool, not tool, but it's a political conversation, but also priority conversation. Health.
Yes.
Now, have we seen a deliberate increase in the financing for health to actually address this political priority for the country in the last 15 years?
Yeah, actually, when we look at the budget over the last 15 years, there has been an increase. Yeah, there has been an increase, there's no doubt, both at the national level and the county level. What we are saying that increase has not been sufficient, has not been adequate to be able to plug into all the holes that we have seen that exist.
Is it as a percentage? Sorry, is it as a has the what is allocated to health increased as a percentage of the budget, or in just relative numbers? Because the budget has increased for sure, so the numbers could be going up just because the budget is going up.
Actually, both increased. We had a nominal increase in the amount, but we also had an increase in the proportion that has been allocated to health. Albeit not to the extent that we will wish to have, because we are talking about between 7 and 9.2% of the budget, the entire budget. Being allocated to health sector.
I remember us having this conversation last year around the budget time with Budgeti Hub.
Yes.
And Dr. Rugo actually now looking at those comparatives.
Yeah.
The increase in allocation for health versus comparatively increase in allocation for, say, security, comparatively increase in allocation for operations and maintenance in government, which is basically China Mandazi, and paint cars and so on and so forth. If you look at that comparatively, the percentage increase, is it justifiably at the place it should be?
No, and that's why we have been talking about inelasticities of the health budget, that the overall budget has grown by a bigger proportion than the growth in the health budget. And that, to me, as an economist, is where I see a problem. Because if you have come up with a bigger pie, I should also be able to get proportionate to the growth. But now other sectors have grown slightly higher compared to the health sector.
Now, I just want to add here, Mungu alali. And this is why I'm saying Mungu alali. That thought just came to me, Mungu alali. And Trump comes and does what he did. Okay? Ruto launches UHC and converts NHIF into shares. So everybody's focus is on health. Now, Trump, everybody's focus again is on health. This is now converting it from an elite political conversation to an everybody's political conversation, as it should be. And so when you talk about political decision making, I'm hoping that these events are making people to start seeing what health necessarily means and how a political decision affects them directly. When a household contribution is 29% to the health burden, 23%, that is very high. That's very, very, very high. If you look at the government is only doing just about double that. That's very high. And if people start noticing that this is such a high burden to me, and yet I'm paying tax, so the taxes can do this and the other, then it starts becoming a political conversation. First, let's discuss pesa ya health. Alafu sasa ndio tuanze kuongea pesa hii mambo ingine.
Because that's essentially, I don't say it's the backbone, but what is a society without health? And the fact that this has been, I guess, politicized and weaponized is insane. I still will want to come back to realistic domestic fundraising, but can you quickly give me an example of a country on the continent, or maybe not, that has effectively tried to balance access to health in a way that has supported the citizens and have perhaps avoided what we're seeing happening right now? Does any come to mind?
No. You made it tricky because you said on the continent.
I mean, if we say we'll go to Nordic. Let's say global.
Wait, maybe there's one on the continent. I don't know. Is there one?
No. In fact, let me first clarify that when we look at the contribution of households, when we talk about the 23%, it's not really bad if it were coming in what we call prepayment mechanism. And that's why this government, we must commend them, because they have tried to reform the health sector to be able to actually maintain the 23%, but let people pay a prepayment. And that to me is good, because you are paying at a time when you are not sick, ideally, so that when you are sick now, that can be covered. But coming to your question, many countries are grappling with this challenge, including the developed world. They are suffering with issues different from ours, but I think we seem to be having similar challenges, especially in the lower middle income countries. We don't have enough to cover all our issues. And that's why countries that are strategic are now asking themselves, where can we effectively invest? Because, and that's why you find the primary healthcare initiative in Kenya is one of those good initiatives, because you are saying you don't have enough, and therefore go and arrest the issues at the grassroots, at the community level, so that you minimize the amount of money that you will be required to spend upstream. Those are some of the innovative approaches that most countries are taking. So when I see community health promotion promoters, I feel like that is the way to go. We just need to find how do we strengthen so that we are able to utilize them to arrest those diseases that will ideally develop into chronic illnesses later, and so on. But in terms of any country having sufficient money to put in health, very few. In fact, they are not there.
Okay.
Including countries like Canada, you find when you read on their reports, the people are complaining their waiting times for theaters and so on have increased and things like that. So they have a slightly different problem because they can access this care only that maybe it's the waiting time. For us, even if you waited, you will not get it.
Domestic financing.
Yes.
Yeah. Realistically, how can we make that happen?
So, and this is why there is a lot of conversation between what the county government can also appropriate to the health sector and what the national government. So the two governments need to work together to ensure that they mobilize sufficient resources to go to the health sector. So the working together will ensure that there is no duplication, inefficiencies are minimized and so on. Because increasing the pie, we have increased, but we have not increased the amount of money that actually goes to the health sector. We've increased, but with very small margin. So, and that's where there is room also to, because remember the Abuja Declaration, many people have talked about it, which recommended a minimum of 15%. So we are at 9.2%. So it means there is room for us to. But if you look at it that way, it becomes very simplistic, because there is also another declaration somewhere in agriculture who said certain amount, 10%. So when you add, it's about
all the declarations,
is above 100%. So
and
you
it's
have
because
to
no one is sitting on the same table. Kila mtu anaketi to say that will be 15. By the time you all come, you're like, oh, what's happened?
300%.
300%.
Yeah. So you have to rationalize so that everybody gets something, because we must invest in all sectors for us to grow.
Right.
Yeah.
True. Okay. When you think of a future perhaps model that is not reliant on donor funding, that has household funding being prepaid, like you've called it. I like that way of looking at it. Who plugs that hole in the middle?
Yeah, like I said,
the donors.
Yeah, like I said, and that's why you see the government that is plugging that through mobilization of other donors to come in. Plus, of course, changing the arrangement, because part of the problem has been if you allow donors to come and fulfill their objectives, you end up with the same problems that you had before they came.
Yeah.
So this time round, now the government is saying, look, we are building our priority lists. Anybody who comes in plugs into this. That is another way of effectively using donor aid, because otherwise you end up with so much money in one program and nothing in another program. And so you spend so much and you don't realize the results. But coming to the point, we don't have enough. So therefore we will definitely rely on donors. So it's just how do we manage these donors?
The donors, to our benefit.
Exactly.
I'm thinking also of our population pyramid, the way it's structured right now. It's quite young, but future looking, as this Gen Z, millennial, Gen Alpha generation grows older, also puts a bigger strain on the healthcare system. Is there anything we can be doing right now to make sure that when that time comes and the population is heavy on the elderly, we are prepared?
So that is why we need to continue building the culture of insurance, medical insurance. In this country, for many, many years, we used just to be up to a maximum of about 20% insurance coverage. And so you realize that when people fall ill, they don't have any resources to rely on. So we need to build this culture, both within the elderly and also our Gen Z, so that they build this culture going forward, because it's the only way I see personally that people will be able, because if we don't build that culture, people will be paying at the point of service. But you see, when you pay at the point of service, an illness may come when you don't have money.
True.
What happens? So
when you say insurance,
yes,
we have a social health authority.
So why are some people not paying?
Because that's it. The Social Health Insurance Fund,
Yes.
SHIF.
Ideally, it's mandatory.
It's mandatory for everybody to contribute.
Yes.
How do you remove the how do you incentivize people to actually contribute at that point? Are there methods that you would propose?
Yeah, there are many ways, because sometimes people pay to an insurance scheme when they think they can see the benefits. So one way is to ensure that the benefits can be seen. And if you go out there now and do some survey, you will see the provider is saying, at least now I'm able to get some 1 million every month to be able to pay for my workers and pay for a few things here and there. Then we also need to go to the patient and ask, are they satisfied? Because when patients get satisfied, if you came from hospital today and then you say, mine has been paid by insurance, your neighbor will say, let me also go and pay.
Let me pay.
So that negativity is what we need to start removing, because sometimes it's driven by mischief or things like that, but what is the reality? I think there are organizations out there that are doing surveys to ensure that they give us proper information about what exactly is happening on the ground.
Right.
And that's one way of incentivizing. Another way is ensuring that people's incomes improve, so that people can now be able to pay out of their incomes and so on.
True.
So there are many ways. And then, of course, community mobilization, like having registration process to be as seamless and easy as possible. Because I know at some point I was struggling. Then I asked myself, if I struggle, how will Mama Mboga at home register if personally I don't know how to? So I know the Social Health Authority has now simplified the process through a code which you just put in, and then it asks for information, and that is the way to actually incentivize and encourage people to pay. And then, of course, they have also come up with Lipa Pole Pole, because sometimes you may not have all the money at once.
Yeah.
But then there is a mechanism where you can borrow and pay for your insurance, and then pay that fund at
Pole Pole.
Pole Pole. Yeah. So there are many ways. It's not one. There are many ways in which we can.
One that comes to mind as well, and I realized this last week when we were in Kawangware, it's community health promoters. I think when you said mobilization, I think that they would be a great resource to use as a way to recruit people into paying for their SHIF and SHA, etc. Because I think we think of them as, I don't know, I realized they do a lot more than we think of. Everything from you're helping a mother who's just given birth, for example, learn lactation tricks, you know, something from that to the preventive healthcare. And preventive also, part of it is now also paying for your insurance. So I think they may be an untapped resource. And the minute you see someone coming to your household just to check how you're doing, to see what's going on, that already tells you that if I pay for this shift thing,
I can see the benefit.
there'll be something.
We downplay their role, I think.
Exactly.
I don't know whether it's how I don't know how we can fix that, because you're right, there's a kind of like an undervaluing of just how much they hold communities together. You know, you may have,
it's a focus of it.
It's a what? Focus.
It's a focus. Look, the technocrats who sit, for example, and design a program such as universal health coverage and say, let's do it this way. Let's put our focus on primary health care. Let's have community health promoters. Let's say one community health promoter shall serve, how many? Is it 100 households? 100 households. Let us map the households and so on and so forth, right? On paper, that technocrat has thought through it. And even gone into talking now to people like Daktari to cost it and say, so how do we cost it? How do we finance it? And then you give that to political decision makers to also to communicate it. And they're communicating it from different angles. There are those who will want to communicate it from a proper political conversation that this is the benefit. And there are those who want to communicate from an entrepreneurial political conversation. And that's why we saw a lot of focus on how many people have registered for SHA. How many people have 24 million. Look at the dashboard. It's showing us how many registered yesterday, you know? And not much on how many are contributing and the push for them to contribute. Not much. And the last time we had the PS here for public health, we asked how many community health promoters are on the ground and what kind of impact are we starting to see? Like how many people used to go to the local health facility for basic things and they're no longer going? Or how many people are not going to the local health facility for basic screening and they're now going? You know that you can start showing our community health efforts are bearing fruit. That's not where the focus of the political conversation is. It is how many people have, how many are stealing, how many are not stealing. That's why I said it's a focus and who's focusing on it.
When I saw on page 2 that it says the deficit could sink SHA, maybe he's spoken to it, but I want him to comment on what this means. The point is, I'm not seeing a way out. I'm really trying to, because again, the over-reliance, I hear you when you say we still have to rely on donor funding. Priorities shift a lot sometimes with donors. They're like climate. You know, tomorrow it's education.
What's hot today?
It's what's hot today. So I'm still like, it's shaky ground. I could be wrong. You're the expert, you know. Then you see a headline like this. So I don't know. Encourage me. Encourage somebody watching today. So they're going to visit their clinic. They don't know that they'll find anything. We don't want to be doomsday about it. But realistically, it doesn't seem like there's a strategic way out that is being prioritized, even at government level.
So, you know, the way insurance works, it works by pulling our risks and resources into a basket and therefore expect that a few of us can therefore utilize. So if many people don't subscribe or contribute to the insurance, we will continue having challenges. So because it's built on that theoretical foundation. So we can't expect like 3 million people to pay and then carry the weight of 57 million people. So, and that's why, to me, my appeal is to people to register. Because when you register, it doesn't mean you are paying so that tomorrow, so that you go to use it tomorrow. You are paying so that you put resources in one basket, so that when a few of us fall ill, then they can be paid through that pool.
And then the trust deficit is what
and so now that
people
is
from
now
paying.
Trust deficit is making people not put money in that pool and so on. So, and that's why when you ask about the NCs, I'm asking them, let them just read about the theory of insurance and then help us. Because you can't say I'm the only one who pays, but when we fall ill, everybody wants to take. Mine will not be sufficient.
The basics, there's a lot of work to be done as far as the information gap is concerned. I'm thinking through the communication impact, or rather the work being done to communicate these funding cuts and how they're being dealt with. For example, in Gina's story, we saw someone, the clinical officer, telling her watu wamestrike, kama nani wamestrike. And essentially,
some health workers
workers on a strike. And that's true in some counties in Nairobi. We've had that issue. But essentially, that's not why you are unable to get that at the moment. So now I think about the communication gaps and the problems they bring. How do we close those, and who essentially should be in charge of communicating that because of this funding cut, we are not able to provide you with this right now, but if you come back in the next week or the next month, or if it's a dire case, I don't know, najaribu tu kuona where the communication gap is.
So maybe before we answer that, we need to understand what was the extent of support, especially on human resources. If you go to the report, we've analyzed county by county how many PEPFAR-supported staff were supported in those counties. And you find some counties had almost 8,000, 3,000, 4,000 staff on donor-supported payrolls. And so when the donor says they can't support such, only two things will happen. Either they continue working for free, or they exit and look for somewhere else where they can work. Now, what that means is that when a patient now comes to that facility where they were working, they will not find a human resource to serve them.
Right.
So, and that's why I said we commend the county governments, because what they did is to write memos around to tell people, now these services, let's provide them in this clinic, all of them, without saying that one is HIV, that one is TB, and so on. What we call integration.
Yep.
So that now the patient can continue getting that service. But remember, if there were 10 people serving and now you are left with 2, they will be overwhelmed. And so the government is now trying to negotiate how do we take up, absorb some of the critical staff who are initially on payroll supported by donors. We now, as government, absorb. That has been conversation
With our 9.2%.
Yeah. And so with the unions and organized groups, if we have 4 of us and then somebody wants to take me, then you say no, we can't allow only to take one. All of us must be taken. So there's a lot of negotiation back and forth.
A lot of
Let's leave it there for now. But thank you so much for updating us on that. And we'll remain optimistic. Somewhere there has to be a solution.
Your voice is not giving
I know it's not.
Fanya hivi, wewe lipa sha.
Yeah, I mean, to be fair, you know what? Yeah, maybe that's the next phase of the conversation.
And I'm saying this because
people,
I actually had some feedback from about 3 people who've gone to different facilities to register for SHA. They register and then they say, so sasa nitakuwa nikilipa ngapi? Si lazima ulipe. Si ungoje kuwa mgonjwa ndio utakuja kupata pesa. Unapatia serikali pesa ya nini? And this is an officer.
And see, that is misunderstanding the concept.
Okay, so we'll thread on that. That is very critical. But we've been in studio with David Khaoya, who is a health economist, University of Nairobi. Up next, we have Your World. Winnie Lubembe is going to be in conversation talking about breaking the silence, understanding lymphedema, I believe. That will be on Your World on NTV and Vibe Shift on Nation FM with Brian Asali and Claudia Naisaba. From us, Janet Bogwa, Mariam Bisha, Eric Latifo, Miriam and Eric. See you again tomorrow, Fixing the Nation on Conversation at a Time.